Hey everyone, my name is Emaan Chaudry.
And my name is Danielle Solish, and today you're listening to the 22nd episode of Seeing Clearly, a pre-clerkship guide to all things ophthalmology. On today's episode, we are going to be interviewing Dr. Bona.
So a little bit about Dr. Bona. Dr. Bona is an eye physician and surgeon at the Kingston Health Sciences Center in Kingston, Ontario. He serves as an assistant professor at Queen's University in the Department of Ophthalmology with a cross appointment to the School of Rehabilitation Therapy. He's also the postgraduate program director for the Department of Ophthalmology. And on completion of his ophthalmology residency at Queen's University, Dr. Bona undertook a traveling fellowship in vision rehabilitation.
He is also currently acting as the chair of the Canadian Vision Rehabilitation Society and is currently the director of the Southeast Ontario Vision Rehabilitation Service. So without further ado, we would love to introduce Dr. Bona.
Thank you guys for having me. Happy to be here. Excited.
Thank you for being here. We appreciate you being on the podcast.
Yeah, we're really excited. So I guess we're going to kick it off right with our questions. And we asked this question to all of our guests. But I was wondering if you could talk a little bit about your journey to ophthalmology and why you went into ophthalmology.
Yeah, it's a good question. Obviously, it's a question that everybody's asked at some point. I got into ophthalmology quite late. I think I was in my fourth year of medical school, and I kind of split my electives between pediatrics and ophthalmology, and so then I went off on my electives, and when I juxtaposed those two very different types of medicine, it became very obvious to me what kind of I gravitated towards, what I aligned with. Like for me, ophthalmology is just such a kind of a satisfying concrete science. Like you can look in the eye and you can see the cells and the inflammation and the nerve and then whatever, and then you can do something about it. And it, for me, it's gratifying that you can. It's just, I don't know, there's something gratifying of the concreteness of it. Whereas in pediatrics, it was trying to, while I love working with kids, it's trying to kind of extract information and they can't really communicate it with you. You're looking at, lab tests, blood work that are acting as surrogate markers for whatever you're looking at. And so, so that part of it, it just didn't jive with me. So when I had those two choices, it was pretty clear what I wanted to do. And then when I was on my electives, obviously pretty late in the game, there's a lot of stress in trying to, build your CV. And so what I was doing was every time I was on an elective, I was just desperately trying to maximize my potential. And so I would try and do, a research project with my supervisor, or I remember one elective, I created a teaching module for the residents on a specific topic, just thinking outside the box desperately, like what can I do to ingratiate myself and build myself up. And fortunately it worked out in the end. And then after ophthalmology, yeah, maybe we'll leave it there. And if you have some other questions, we can dive into it. But for me, it was a late start, and but definitely the right decision.
Well, thank you for sharing that. I think from a medical student perspective, it's always reassuring to hear the stories of, in your interest being a little bit later in your journey to ophthalmology, just because it shows that you never really know where your life is headed. And clearly, you were interested in two different specialties, which is interesting to see, and you gravitated towards one, which is, it's nice to see that you found that late, but still pursued it anyways, and it all worked out. So thank you for sharing that. Now that you are an ophthalmologist, do you mind maybe telling our audience a little bit about what your day looks like? So maybe how you manage your work as a specialist in low vision, but then also being the program director and your comprehensive practice as well.
Yeah, so I obviously wear a few different hats, and it can be tough to juggle all of them. I would say if I had to put an order to it, the program director administrative duties probably takes up the bulk of my weekly practice, and then I also have kind of the comprehensive surgical general ophthalmology practice, which is kind of second, and then the kind of the third kind of most intensive part of my week is the vision rehabilitation practice. like the fact that there's such variety is fantastic. I think if I was doing the same thing every day, day in, day out, it would become, monotonous pretty quickly. Sometimes I get, it's frustrating just to have juggling so many different balls at the same time. But if I were to like honestly reflect on things, I think having that variety is crucial, and you can get that anywhere. It's up to you how you build your practice, but I think creating a little bit of variety is important. The I think there's been a transition over the years where in the past it used to be that you'd be a general ophthalmologist through and through, or you'd be a uveitis specialist, or you would be substitute any subspecialist, and that's kind of all that you did. And what I'm seeing more and more now is that people are graduating and then doing areas of interest, right? So not necessarily fellowship trained. So for me, when I was graduating, I kind of looked at our department and saw, what are we missing here? And at the time, I saw that there was just this intense focus in ophthalmology on metrics and numbers. So what is the RNFL thickness, the central macular thickness, visual field defects, but none of that actually related directly to how patients function on a day-to-day basis, which is really what we're trying to influence. And so that's where kind of the vision rehabilitation piece came in, and that was sorely lacking. And so so at that time, I kind of there wasn't there were fellowships that existed, but I had a young family, and for me to take off for a year and embark on a fellowship was kind of too much of a personal sacrifice. But trying to think outside the box, what could I do in its stead? And so I looked up basically different subspecialists in the field across North America, and planned these kind of 2-week, 1-month stints with them where I would go, come back, practice ophthalmology here as a locum, go, come back. And then in the aggregate, after a year, I had enough kind of expertise that I could come back and start my own practice. And in the past, it used to be that, again, if you were even a vision rehabilitation specialist, that's all that you would do, 5 days a week, 52 weeks out of the year. But for me, I wanted to be more of an area of interest, just like we have comprehensive ophthalmologists who do have an area of interest in plastics, or have an area of interest in medical glaucoma, or medical retina, or what have you. So for me, it's kind of general ophthalmology, some administrative duties, and then kind of this area of interest, this niche that I can offer to our department. That's vision rehabilitation.
Oh, that's incredible. It's also nice because then you can feel interest in different specialties in different areas. Like if you had an interest in medical education, but also in practicing, and then you get to kind of format your week around that. That's incredible. I can understand how it can get so busy, but that's awesome. Just kind of a follow-up that's semi-related to that. I was wondering if you could talk about like how maybe you, or maybe just in general, specifically how to integrate like research into your clinic or into your practice, and how like individuals in ophthalmology can balance that, whether that's specific to you or others.
Yeah, that was another lesson that I learned along the way. So when I started, I did those traveling fellowships. I came back, and then it was kind of like a one-man show where I had some demonstration devices, and it was very patient centric, very targeted, and trying to kind of just be as efficient as possible. But that approach does not lend itself well to research. And I had a really great colleague who worked in our department as the research director, and we kind of sat down. They're like, if you really want to do this, you have to build kind of the culture and the infrastructure in place in your clinic so that research becomes almost organic and easy. And so, like, what did that mean? That meant so we actually ended up purchasing our own standalone electronic medical records that nobody else in our hospital uses, because vision rehabilitation is a very it's not a cookie cutter specialty. And so we bought something that was customizable. We built it from the back end, and so that now not only does it suit our clinical needs, but it suits our research needs. It creates a database that we can draw on information. We can decide, like, let's do a study on microperimetry. Well, we can immediately, filter different results, flag things, extract data, export them into SPSS, and it just became much easier. Also, understand from a cultural standpoint, understanding that people should just collect data as a matter of course, like, because you never know when you're going to need it, what you're going to want to draw on. So if you're doing this, if you're doing everything for everybody always as a part of your normal clinical exam, then when you kind of go back retrospectively, it's very easy to extract, and there won't be many gaps in the data. So I think those were a couple of lessons. And then so now when I'm doing research, it's much easier when I have a resident or a med student, where we can kind of come up with an idea together. And I'm like, I've got this database here. Let's go mine through it and see what we can come up with. So it just makes it easier. The one thing I would say is that there's a differentiation between like big R and little r. So big R is like research is your raison d'etre, like you're getting big grants. It's like you're spending half your time, half your week doing research, and the other half is clinical, versus little r, which is what I am, where it's kind of, again, like an area of interest, something that you dabble in. Sometimes you spend a little more time, a little less time, but it's not kind of the purpose for my existence in our department. So somebody who's a big R might have very different advice, but from a little r standpoint, I think this works out well.
Well, thank you for the advice and kind of breaking it up into those categories. It's nice to see the two and then see how you're going about your research. It seems like everything you do is quite innovative and on your own path and is guided by your passion. So that's also really nice to see. So thank you for that. Branching a little bit away from academia and ophthalmology, I was wondering if you mind sharing what types of things you enjoy doing for fun outside of work and how you're able to balance that in addition to your other practice.
Yeah, so work-life balance. I'm not great at it. I'm sure my family can attest to that. So yeah, so I just to give you a little background, I have 3 young kids, and so the moment I'm done work, I go home and it's all family all the time, and then rinse and repeat kind of day after day. So they're my kind of my extracurricular. I do try and I enjoy cycling, so I try and if I'm on the trainer first thing in the morning before clinic, or I used to be able to get out more, but not so much of late. So that's kind of one thing that I like. In the winters, I like to play hockey. But again, my games are always at night. So you can see that whenever the kids are asleep, that's my time. And I kind of fill it with different activities. The other thing is I really like the outdoors. And so our family often goes up to so obviously I'm from Kingston, and there's really nice lakes and green spaces north of the city. So we're up there most weekends.
That's excellent. Well, when the kids get older, then you'll have more time before, maybe a little less time after, but
I'm just waiting.
Fingers crossed. No, that's awesome. I know it's always easier said than done to balance, but having a family is of course like an amazing commitment to have. Now, I guess just ending this off with one final question for all our listeners. I was wondering, since you're working at an academic center, if you could talk a little bit about any advice you have for learners, anyone who's doing like a clinical rotation or like interested in ophthalmology.
I think maybe my advice would be just kind of to be authentic with who you are. I had a fairly, at least maybe before ophthalmology, a fairly linear traditional path in terms of undergraduate studies, med school, and then residency. But the longer I've been doing this, the more I see that people have had some atypical routes, circuitous routes to where they ultimately ended up. And they had like these really interesting, wonderful experiences that I'm sure they're better off for it. And so not feeling, not feeling compelled to take the most direct path, and whether it's feeling pressure to do, like I've got to do a research fellowship to get where I want, or rather maybe do something out of interest and passion. And I think that probably will say more about you and express more of who you are, and I hope will kind of get you where you want to go in the long run. And maybe the other thing that I would say, which again I'm not always doing a great job with, but letting people know that they have the power to control their environment. So what I mean, like when you're a resident, or so when you're a med student, for example, kind of what I'm saying, you have the power to decide, I'm going to go on this really exciting elective to, South America, whatever, as opposed to doing research all summer. But when you're older, when you're kind of further along as a faculty, often people feel compelled to do clinics, but no, you can create boundaries, and you can adjust your clinic. You can create areas of interest. You can mold the type of practice you want to lead, whichever way you want. And I don't think people understand that. And obviously there are degrees, like sometimes you're restricted by, your environment, your clinic, your OR time, whatever. But as long as you're, thinking about like what's important to you, what are your priorities, you can actually kind of modulate things and adjust things to steer you in that direction. You just need like the confidence and to know that it's going to be okay.
Well, thank you for sharing that, because I think just sharing that will hopefully give some of our student listeners the confidence to pursue their passions and to do exactly what you said. So thank you again for sharing that. We're done with our academic related questions. Now, as our listeners know, we move into our Would You Rather segment. So I'll start off, and then Danielle will ask you a second question. But for the first question, would you rather work 80 hours 1 week and have the next week off, or work 40 hours for 2 weeks?
Oh, I would I would rather do 40 hours a week. The better question is, what would my family rather? So I'm going to defer to them, but I don't know. I would do 40 hours. I think I'm a slow and steady kind of guy, and that seems a little too like manic and like hyper focused for me.
I was going to say it's a lot all at once and then just nothing. And that on repeat seems hard to sustain.
Yeah.
You'd probably just be so tired the week after that it would be hard to make up for it, for sure.
I would have gone into shift work. I would have gone into like Emerge or something.
Yeah.
That's totally valid. And then my question is, would you rather receive a catered lunch every single day, but never get to choose what you order, or have to pack your own lunch every single day?
So I would rather, I would definitely rather a catered lunch, because I'm not picky, and it would just be exciting. But so I pack my lunch every day, and I open the fridge and I look for all the leftovers that our kids and our family haven't eaten, and I try and clean the fridge as much as possible. And there's something so gratifying again about just getting rid of leftovers, and if I didn't do that, we'd be throwing out tons of food. And so I would actually go with option B for the good of our fridge.
I was going to say it's very like environmentally sustainable, no food waste.
It is, but it's actually, there's like this selfish compulsion that like, oh, I got rid of that. That's great.
Exactly. You feel good about it when you're eating it.
Yeah.
Well, with all of that, we've wrapped up the episode. So I just wanted to say thank you again for being a part of the episode. And for our listeners, thank you so much for listening to this episode of Seeing Clearly, which is our pre-clerkship guide to all things ophthalmology. You can also stay caught up with everything else that iCurriculum is doing. So check out our website at www.icurriculum.com and be sure to follow us on our social media at iCurriculum. Thank you again, Dr. Bona, for doing this interview with us.
Guys, thank you for having me. This is a great initiative. Much appreciated.